Yeah, thank you very much for having me this evening. My name is Vicki Kirwin. As I was introduced earlier, I'm a policy advisor at the National Deaf Children's Society, which is a UK-wide charity for deaf children and their families. Prior to working with NDCS, I worked as a paediatric audiologist, and my experience in that area comes from working at Great Ormond Street Hospital and working with children who have quite complex needs in addition to their deafness. I've been asked to explain a bit about how meningitis results in hearing problems. I'm going to try and raise awareness of some of the psychological impact of being deafened on individuals, and hopefully increase your confidence in seeking support for any hearing difficulties if you need them, which may or may not have been identified prior to this session. I am going to be talking mostly about children because that's my area of expertise, but there is a lot of overlap with adults, and I hope there'll still be some useful takeaways for you if that's the camp that you're in. So I'm going to show you a brief video. It's only a couple of minutes long, and it's just a simple explanation of how the ear works, and it will help us to describe how meningitis affects the ear. And this video does have its own subtitles, so you may get a break for a couple of minutes.
Have you ever wondered how sounds make their way from the source all the way to your brain? Take a trumpet, for instance. When it's played, it makes sound waves in the air. The outer ear catches the waves, which then travel through a narrow passageway called the ear canal. The sound waves reach the eardrum, which is a membrane roughly half the size of a dime. They make the eardrum vibrate, which in turn vibrates 3 tiny bones called the malleus, incus, and stapes. These bones amplify or increase the sound vibrations and send them to the cochlea. The cochlea is shaped like a snail and is the size of a garden pea. It is filled with fluid, and the sound vibrations make this fluid ripple, which creates waves. Hair-like structures called stereocilia sit on top of hair cells and are grouped together as hair cell bundles inside the cochlea. The hair cells inside the cochlea ride these waves, and the hair bundles are moved. The hair bundle on top of the hair cell turns these movements into electrical signals. As the hair bundles are moved, ions rush into the top of the hair cells, causing the release of chemicals at the bottom of the hair cells. The chemicals bind to the auditory nerve cells and create an electrical signal, which travels along the auditory nerve to the brain. Different hair cells respond to different frequencies of sound. The hair cells at the base of the cochlea detect higher-pitched sounds, such as a piccolo or flute. The hair cells toward the top of the spiral detect progressively lower-pitched sounds, such as a trumpet or trombone. At the very top or apex of the spiral, the hair cells detect the lowest-pitched sounds, such as a tuba. The auditory nerve carries the electrical signal to the brain, which interprets the messages as sounds that we recognize and understand.
Sorry, I'm just struggling to move the presentation on, so let me sort that out. Okay, Apologies for that. Okay, so what we saw there in the video was a summary of how the ear captures sound and how that sound moves through the ear. The way that meningitis causes hearing loss is most commonly as a result of the infection itself spreading into the cochlea, so into the inner ear. The cochlea was the part of the ear that we saw that looked like the snail shell, and they described it as being filled with fluid and with hair cells, which generated an electrical charge when they heard, when they received the signal. So sometimes the infection itself damages those hair cells and prevents them being able to detect the sound waves as we would expect. Sometimes meningitis infection causes inflammation or swelling of the auditory nerve itself, so the nerve that passes between the cochlea in the inner ear and the brain. We also know that for some people, meningitis affects their vestibular organ, which is the other part of the inner ear, which is the organ that helps us to balance. So it has an impact on balance, movement, unsteadiness, whether we feel a bit disorientated in space. The other effect that meningitis can have is a condition called ossification, which is when the bony outside of the cochlea grows inwards on itself. It obliterates the hair cells and the fluid, and it sort of fills up with this bony substance and stops the cochlea working as it should. That happens usually quite quickly after meningitis. For those people, it's going to happen. And it's one of the reasons why anybody who's had meningitis, it's recommended that they have a hearing test quite quickly so that we can determine what sort of damage has been done to the inner ear. We'll have a bit more of a look about ossification in a second by looking at this scan or X-ray. So this is an X-ray of the inner ears. You can see the right and the left inner ears. The one on the right, you can see I've marked as patent, which means that ossification hasn't gone into those channels inside the cochlea. The one on the left-hand side, you can see it's much more whited out because we're picking up more bone in the film, and that is ossified. That would mean that that cochlea would not be functioning well. It would not be able to pick up sound because the hair cells and the fluid in there that make it work are no longer present. In children, the biggest cause of acquired hearing loss, that's children who are born hearing but develop a hearing loss during childhood, is caused by meningitis. So it is something that we're very aware of, and that does need to be assessed and monitored after treatment. For all newborn babies in this country, we offer a newborn hearing screen shortly after birth, usually within about 2 days of being born. And we're looking for the 1 in 1,000 babies who are born with a hearing loss. We're usually born with a hearing loss. So childhood deafness usually is quite rare. When we test the hearing of babies who've spent any time in NICU or special care baby units, either because they've been extremely premature or they've been very poorly around the time of birth, then their risk rises to about 1 in 100 babies who will have a hearing loss. So we already know that's a group that are quite at risk of deafness at birth. But for neonates who have had meningitis, that risk goes up to 1 in 10. So for those babies, if they've had meningitis, we don't test them through the usual newborn hearing screen. They should be referred directly to the audiology clinic for a full assessment of their hearing. In older children who have had meningitis, the recommendations are for an immediate referral to be made to audiology, for an age-appropriate hearing test, and they should be seen within 4 weeks of discharge from hospital or within 4 weeks of being fit to test. So we do know that some children will go home before they're able to do a full hearing test, but we want to be able to see them as early as we possibly can. We know that the majority of children who are deafened by meningitis, it happens before their 3rd birthday, quite early on in life. I'm just going to take you through this picture, which is of an audiogram. That's a graph which we plot hearing test results onto. Across the top, you'll see the numbers 125 up to 8,000, and this is frequency. This is the pitch of the sound. So it's just like a piano keyboard with the low pitch sounds on the left-hand side and the high pitch sounds on the right-hand side. As we go down the graph, the sounds get louder and louder. So anything at 0 to 20 at the top of the graph is considered to be normal hearing. Anything right at the bottom of the graph, 95, 100, 110 is a profound hearing loss. But we know meningitis can cause hearing loss in lots of different ways. We can have hearing loss in both ears, or it could be that it's just affected one ear. That's bilateral or unilateral. We know that the hearing loss can be any level from mild to profound. We also know that it can affect different frequencies, that it could just be the sort of the outside part of the cochlea where the infection managed to get to. And we saw in that video that the outside part of the cochlea is where the higher pitched sounds are. So you may hear low pitched sounds well, but not hear the higher ones. We do know that hearing loss normally happens quite early on in the course of the illness. But it may not always be immediately stable. So sometimes we need to do a few hearing tests over time. That could be because of the impact of, waiting for that inflammation of the hearing nerve to go down, or because we're waiting to see what happens with the ossification. So sometimes it takes a few hearing tests early on. I'm going to ask you to do something while sitting in your living rooms watching this. We're just going to have a look at some of these sounds. So these are all of the speech sounds from spoken language in English. I've just put a purple ring around some of the lower frequency or the low pitch sounds. And I just want you to sort of just say to yourself some of the sounds within this circle. So if I say something like m, b, d, okay. When we say these sounds, they're quite low pitched. They're quite strong on the voice, and they're quite, so they come across quite loudly. Now I've put a circle around some of these high frequency sounds. This is and because of the microphone and the limits of talking over camera like this, you may not have even heard me say them. But if you just say those sounds to yourself again, and you can hear a really big difference. They're a much quieter sound, they're more high frequency. If you look at them, they're also the sounds that make up the beginnings and the ends of words. So actually you can hear some sounds, or if you hear some sounds that are better in your lower frequencies, but you don't hear the high frequency sounds, you can hear that people are talking to you, but you can't necessarily make out every single word in that sentence because it can be, because you're missing the beginnings and the ends of some of those words. When you're an adult, that is a massive irritant, but we've often developed our language brain by then, and often our brain is very, very good at filling in those gaps for us. So if you don't hear the beginnings and ends of every word, that's your brain fills that in for you, you can still understand what's being said. But if you then go into an area where there's a lot of background noise, which really obliterates even more of those speech sounds that you want to listen to, it can become harder and harder to communicate. So you start to see that even quite a mild hearing loss, quite a slight hearing loss, can actually have a big impact. If you're a child when this happens, then you don't have that language development already. So you have gaps in your knowledge, and if you don't understand the context, or you're learning new vocabulary, you're learning new words every day, you can often miss those sort of beginnings and ends of words. So you can see that the impact of hearing loss changes depending on exactly what frequencies are affected and exactly what level of deafness you have, but it certainly does have an impact on everybody. What's also worth knowing, listening to Mike and previous speakers, is about listening about cognitive decline and about fatigue and about, exhaustion. What the research shows us with adults with hearing loss is that even a mild hearing loss can have a big impact on fatigue because it's more exhausting. You have to use those cognitive resources to fill in all the gaps of the things you're not listening, you're not hearing as well as you should. We do know that fitting hearing aids to older adults who start to lose their hearing through the natural aging process can have a preventative effect on cognitive decline in older age. So whilst I can't directly tell you that it's something you need to do if you're younger and post meningitis with a mild hearing loss, I certainly think that there is nothing to be lost by getting hearing assessed, by trialing some hearing aids maybe, and trying to reduce that cognitive load, making listening easier for yourself, because all of that will have an impact on fatigue levels and your cognitive load. Okay. So if you're a child, that impact of acquired deafness or developing a deafness during childhood, the impact depends on lots of different things and will be different for different children. It may depend whether you're prelingual, so if you haven't learned any language yet. If you're postlingual, you've got a different set of challenges. It can depend on the degree of your deafness. Can you get by with a milder hearing loss, or has your hearing completely gone very rapidly? And all of this obviously having an impact on home life, education, social development. Just a few things with prelingually deafened children. So that's children who haven't acquired all their language yet. We need to think about how we can support them with that language acquisition and use. Are they going to be aided in a way that they can use spoken language? Are we going to be looking at whether they need to be using sign language to communicate? We need to think about incidental hearing for learning. So all of us, we learn from things that are going on around us, and children in particular learn about 90% of their language from what's going on around them. What I mean is that they're not learning their language and vocabulary just from their day-to-day school. They are learning from hearing other people, that's children in the playground, or siblings, older siblings at home, parents, grandparents, and other people that they're interacting with. They're often overhearing things that we don't necessarily think it's important for children to hear, but it's really important for their learning of how the English language works and grammar, building their vocabulary. And if you have a hearing loss, you miss out on all of that. We know that children's behaviour may well have changed following meningitis. We know that they may have a shorter attention span, that there may be temper tantrums, they may be more clingy. All of these can be reactions to being extremely ill and being in hospital. They could be reactions to suddenly losing your hearing very quickly. So there's lots of things we need to tease out there. And we know that it can have an impact on siblings and how they react if suddenly all the focus of attention in a family is on a deaf child. For those children who are postlingually deafened, who have already developed a level of language, these are going to be our oldest children. There's often a huge emotional impact from the illness alone. And then there is additional emotional impact and having to accept having a hearing loss. They are often not the children who have grown up with being part of the deaf community. They are unlikely to have parents who are deaf. They are unlikely to know other people who are deaf. We need to work with them on how they can maintain the speech and language skills that they have, as well as developing it going forward. They may need support finding new ways of communicating. If they are suddenly deafened with a profound hearing loss, then they are going to need a lot of support because they simply won't get their hearing back immediately using hearing aids. Talking about incidental hearing again, and our older children, really important, not just for learning, but it's also where they pick up the gossip and things like that. And it's part of being that social acceptance and being the same as your peers. Listening fatigue that I mentioned earlier is a big thing. It's hard work listening and communicating with a hearing loss. And if that's new and you're tired anyway, and this is likely to be another side effect of meningitis, then this is all sort of, building on the pressure. We know there's going to be this psychological impact because they're having different experiences to their peers. There may be unwanted or higher levels of adult directional attention, additional support that they're getting in school. They may not want all this professional intervention. They may just want to be trying to get on with their lives. And we know that all deaf children have a higher risk of mental health problems because of lots of things that we've mentioned. So it's something we do need to be acutely aware of. Okay. There are lots of things we can do. Hearing aid or implantable device. I'm not going to go into all of these different devices, but there are lots of options that are available, and it's worth exploring if that's something that interests you. The most common ones are sort of the conventional hearing aids, which amplify sound to a level where the damaged hair cells in your ear can still process some of that sound. If we can't bring your hearing up enough to be able to hear spoken language with hearing aids, then a cochlear implant may be an option. So this is a surgically implanted electronic device that goes into the cochlea. And then there is an external part worn on the head, which picks up the sound and then feeds back the electronic signal. Where I've just put a purple arrow on the screen pointing to the electrode, you can see it's curled like the cochlea. That's the part that needs to go right into that cochlea. So earlier on, when I mentioned about ossification, and I said there was a reason why we refer children and adults very quickly for hearing tests following meningitis, is because if that ossification has happened, it is impossible to put in a cochlear implant fully. So if it looks like a child or adult has a profound deafness following meningitis, then they need to be fast-tracked through the process to have a cochlear implant if that's something that interests them, hopefully before that ossification happens. Lots of other things that can be done to support children who lose their hearing, which I won't go into all the details now, but certainly people can follow up with us afterwards if there's anything you're interested in that might support hearing loss for you. And for children, I think it's fair to say they're likely to get a lot more support than adults currently are for post-meningitis hearing loss. So as soon as they're diagnosed by the audiologist, they are referred to a teacher of the deaf, which is a specialist employed by the local authority, who will go in and support the school and make sure that things are adapted as they should be and that children are able to learn. They may have support of a speech and language therapist. They're probably still under their paediatrician, or they may have an audiovestibular physician, which is a doctor who specialises in ear and balance disorders. They may have a support assistant at school, a social worker for the deaf involved. They may be assessed by an educational psychologist looking at what their needs are in school. They may even have a clinical psychologist to support with some of this psychological impact. So I'm going to end there. We have lots more great information on our website. If you want it, it's all free and available to download. And if anybody wants to talk about any options for children, do by all means contact our helpline. We're there every day, and you can talk to an audiologist about any worries, or how to go about next steps. Thank you.